So number 10 is the foramen magnum. The contents would be the spinal cord, the spinal artery, the vertebral artery, the apical ligament of the odontoid peg, and the medulla oblongata.
See. Number 15.
Number 15. Where am I looking for number 15? Yes, so number 15 would be the hypoglossal canal.
And what about number 20 and number 3?
20. Number 3 is the carotid canal.
20.
And number 20 is, it's not the internal auditory meatus. No, that's right at the back. Not too sure of number 20.
How would you see the internal auditory meatus from the outside? You will never be able to see it, right?
No.
Because it's internal, right?
So it would be the jugular, is it jugular foramen then?
Correct. You're missing the side. So what's the side here?
Yes, so it is the right-hand side, right jugular foramen.
What is number 9?
Number 9 is the foramen lacerum. Yes, it's the
Correct.
false foramen.
11 and 12?
So 11 is foramen ovale and 12 is foramen 47. Not too sure. It's not
It's
the
a stylomastoid foramen. All right. Fine. So I think here with the contents, hypoglossal canal, hypoglossal nerve, jugular foramen, jugular vein, internal jugular vein, parotid canal, foramen lacerum, which is not a true foramen. It's fibrocartilaginous in the lower part and a carotid artery in the upper part. 11, ovale, which contents would be ovale as well.
Ovale,
And 12, spinosum. What's the content of spinosum?
So the contents of spinosum would be the middle meningeal artery.
And 47 is stylomastoid. What is the content of stylomastoid?
So that would be the facial nerve and also the vestibulocochlear.
Why would vestibulocochlear come outside of the
Sorry,
skull?
hypoglossal.
So what would be then? 15 of the hypoglossal canal.
It's the facial, and I think
It's just the facial.
Just
the
the
facial
facial,
and the stylomastoid artery as well, if you want to add that. But the facial needs to come out. This is one of the branches that will come out of the cranium to the face. But internal or the vestibulocochlear doesn't really come out because it ends into the inner ear. So it doesn't really need to come out. So the internal surface of the skull. 7, easy to say, right?
yes, foramen magnum.
And
27 would be your hypoglossal canal.
what's the lateralization here? Which side?
Oh, so that would be your left hypoglossal canal.
And 30.
So 30 is the jugular foramen. 28 would be the internal acoustic meatus.
And 10.
Then 10 is foramen lacerum.
And 14 and 12.
So 12 is foramen ovale. 14 is foramen spinosum.
And 13.
So 13 is the foramen rotundum. Foramen rotundum.
Contents?
Of the foramen rotundum would be cranial nerve 3, 4, and 5. Oh no, it's not. There's only one thing that goes through that. It's the axillary nerve.
The maxillary branch of the trigeminal. What about 34?
That's the optic canal, which the optic nerve will come from.
Amazing. All right.
And then I think 43 is tegmen tympani. Is that right?
43.
Yes.
And what about 42?
That's your supraorbital fissure.
And what are the contents?
So the supraorbital fissure will contain the cranial nerve 3, 4, and 5. The supraorbital.
When you say 5, 5 is as 3 subdivisions, right?
Yes.
You already said that number 13 takes the maxillary, which is a branch for. Number 12 takes the mandibular, which is again branch of 5. Do you think it's right to say 5 is content of 42? I don't think so, right?
No, it'd be 3, 4, and 6.
Correct. What else?
It contains the supraophthalmic vein as well in there, but not the artery.
So there is an easy way to make out the contents of the superior orbital fissure, right? So you're talking about those 3 branches, the lacrimal, nasociliary, and frontal. So are branches of the ophthalmic, right? Lacrimal, nasociliary, and frontal. I always remember them together. And then 6, the superior ophthalmic vein, right? Lacrimal, nasociliary, and frontal. 3, 4, and 6, and superior ophthalmic vein. Other things that can help in studying other areas is
one is the clinoid process. Clinoid.
It's the anterior clinoid because you have the anterior clinoid and the posterior clinoid, and also there is a middle clinoid as well. You don't need to worry about this, but this is the anterior clinoid. The reason why I ask this because the boundaries of the middle cranial fossa.
So it'd be the lesser wing of the sphenoid, the squamous part. squamous part of the temporal bone,
41.
41, and then the petrous part of the temporal bone, which is 37. And then you've got dorsum sella, they've got the tubercular cellum, and then the anterior clinoid.
So anterior clinoid, tuberculum sella, dorsum sella, and the clivus is number 4.
Clivus, yes, yeah.
These are the boundaries of the metacranial fossa. Very good. All right. I'm sure we've done lateral neck dissection. Have we done all of these images?
Yes, we have done.
We talked about metacranial fossa and its contents. There are some important pictures here. Have we done these as well?
Yes, I think so. So
just to make sure that we're happy with it, just tell me this one and number 24.
So 28 is I think 24 is the optic nerve, and then posterior to that, coming under that, is the internal carotid artery, 28.
Perfect. All right. Yeah. Just to double check as well, I want number 19 and number 40.
Number 19. Oh.
Did we talk about the cranial nerve rules?
So I think 14, is that abducens?
What I said 40, this one.
40. I'm not too sure.
So what is 16 then?
16 that's not the pituitary stalk.
No. The pituitary stalk is that. 16 is the butterfly, right? This is your
midbrain.
That's your midbrain. So we talked about the rule of 4, the 2, 2, 4, and the 4 in the midline will be 3, 4, 6, and 12. All right. So here you're in the second 2, from the 2, 2, 4, 4. You're in midbrain, so you have the third nerve and the fourth nerve. So 19 will have to be one of them, and 14 will have to be one of them. 1 is anterior, and the only branch that comes posteriorly is the
trochlear. So it's the trochlear nerve.
So 40 is the trochlear, and 19 is the oculomotor nerve.
19 is the oculomotor nerve.
Fine. These are the main stuff here. Again, this one is very good to apply the rules of the cranial nerves. Again, what are these? Number 4.
So you've got oculomotor, and then the internal carotid artery.
Are you sure this is oculomotor?
The optic nerve, sorry.
Optic nerve.
Yeah. Optic
what
nerve.
Is number 6 then?
So 6 is the oculomotor nerve.
What is number 9?
And then number 9 would be the trochlear.
And what is number 7? I'm going to ask you the question different. Is this a midline structure or a lateral structure coming from the brainstem?
I think it's a lateral structure.
Well, it's sort of lateralized, but the midline here is talking about here. So it's at the same level of the oculomotor, right? So it's sort of coming from towards the midline. This is a proper lateral structure, right? 15 and 16. So it's still in the midline. So that will be from the one that you divide 12 with, right? So 12, 6, 4, and 3. So we've already answered 3 and 4. So that would be 6. Because you cannot see 12 from here. 12 will be all the way down. What about
15 and 16? So they're lateral structures, aren't they?
Lateral structure are coming from the pons, just after the midbrain. So if we go back to the rule, the 2, 2, 4, 4, it cannot be ophthalmic, it cannot be olfactory because this comes from the cerebrum. It cannot be 3 and 4 because these are midline structure. It cannot be 6 because these are midline structures. But it's going to be the 5th nerve because it's a lateral structure, and the 7th and 8th nerve. So this is 5 and this is 7 and 8. Okay. Again, here, I know we might have done it, but very quickly, I just want to make sure that you got the right.
This is the smoking man, isn't it? So 5 would be basilar, and then I get these confused now.
So it's simple. Let's try to break it down. So the brain cerebrum,
anterior
so this is, you have anterior cerebral, middle cerebral, posterior cerebral. And the cerebellum supply, you have superior cerebellar and inferior. And the inferior one is divided into anterior inferior and posterior inferior. That's the blood supply for the whole brain. We need to find this here. So this is anterior. So the one in between will be the anterior cerebral artery. And this is the middle part. So the 15 will be the middle cerebral artery. And this one, 27, will be your posterior cerebral artery from the posterior circulation. This is your cerebellum. The highest one here is the superior cerebellar artery. And you will have one coming from here. This is the anterior, because it's anterior as you can see. Inferior cerebellar artery, again because it's inferior. And this one here coming from the vertebral would be 29. That would be the posterior inferior cerebellar artery. Okay. Fine. We talked about blood supply of the larynx and the complications, right?
Yes.
The nerves. We talked about, I'm sure we talked about oculomotor nerve before, but after, given that we already talked about where it's coming from, it's coming from your midbrain, and where does it leave the skull? It leaves through the superior orbital fascia. So we already talked about this. Now you should be able to work out the course. right? So the course, you will say it originates from midbrain in the midline and leaves anterior in the middle cranial fossa. And when it's coming out, you see that? So you still want to mention this. You want to use the chance and mention it because you already know it, right? When it's coming out from the midbrain, it comes between two vessels. And these are posterior cerebral artery and the superior cerebellar artery, the man that's holding the cigarette. And then it leaves the skull through supraorbital fascia. Yeah. Supply, what's the supply for oculomotor nerve?
So it supplies the oculomotor muscles, wouldn't it?
What is that? There are many oculomotor muscles or extraocular muscle.
So I think it's I'm not too sure.
So it supplies all the extraocular muscles except, have you ever heard this term before? SO4 and LR6.
So apart from the one supplied by the abducens.
So I always remember this way, all the muscles except SO4 and LR6. SO, that's superior oblique, and LR, that's lateral rectus. What else? It also supplies the levator palpebrae superioris muscle and the molars muscle. It's important to know these because you can work out. I don't think they will ask you what does it supply, but they will ask you what are the signs of oculomotor nerve palsy.
So that's down and out, isn't it?
Down and out, and the reason why down and out, because you have the lateral rectus is working, so that will pull it out, and the superior oblique is working, and that will push it down. What else? The patient will have mydriasis because the molars muscle will be paralyzed. The molar muscle is responsible for meiosis, basically. And the patient will have ptosis because the levator palpebrae superioris, from the name, it's a levator palpebrae. It elevates the eyelid, will be damaged as well, or will be paralyzed. Cool. What's the structure that the oculomotor nerve is pressed against? I want to take you back to this one and also this one. Can you see the oculomotor nerve? You can see something here that the nerve is pressed against, and the same thing here as well.
Is it the cavernous sinus?
Not really. No. So it runs inside the surface of the cavernous sinus, but basically this is the tentorium cerebelli. The tentorium cerebelli have a free border, as you can see here. This is the free border, and it also has an attached border. So this is the attached border of the tentorium cerebelli. So see what I'm trying to do? I'm trying to use the images that's available in the notes to study difficult areas. So the structure that's pressed against is the attached border of the tentorium cerebelli. Can you tell me
the signs of facial nerve palsy? So you'd have a sensory function and a motor function. So the motor function would be loss of muscles of mastication, and the sensory function would be loss of taste in the anterior third of the tongue.
So I think mainly here the question is asking about the upper and lower motor neuron symptoms, right? So what's
forehead sparing versus
the facial nerve? It supplies the muscles of the face, not necessarily the muscles of mastication, right? So muscles of the face. Sorry, So the upper motor. What's the difference between upper motor neuron and lower motor neuron?
So with upper motor neuron, you do not get forehead sparing, whereas with lower motor neuron, you do get forehead sparing.
Are you sure?
So lower motor neuron, forehead sparing; upper motor neuron, no forehead sparing. So say
that's not the main difference, really. So with lower motor, what is lower motor neuron? So basically, you have the nerve coming all the way down, right, until there's something called the first order neuron. So it comes from your cerebrum until the nucleus in the midbrain, right? So up till the nucleus in the midbrain, this is the upper motor neuron. And then from the nucleus all the way down, this is the lower motor neuron. So lower motor neuron, if you go and cut the nerve inside the parotid gland, right? So that's lower motor neuron. So you will have ipsilateral paralysis of the whole side of the face. But if it's an upper motor neuron, if you cut it, if your patient has a brain tumor in the cerebrum that's affecting the facial fibers, to be contralateral paralysis of the lower part of the face. So that's the difference. One is ipsilateral whole face, one is contralateral lower face. Don't get too attached with the fact that one is forehead sparing and one is not forehead sparing, because that's not really the main difference. One is ipsilateral whole face, one is contralateral lower part of the face. All right. You can be asked a question why the upper motor neuron will spare the forehead.
Is that because you have I'm not too sure. I think it's just to do with the path that it decussates across.
No, not the decussation, but I want you to have a look at this image, right? So what actually happens in the pathway? You have your afferent coming from the forehead up to this nucleus, right? And then, talking about the forehead, from the head to the nucleus. And then this is the nucleus of the forehead. It will have bilateral representation in both sides of your brain. But your lower part of the face will go all the way up to the nucleus. and it will have contralateral representation, only just contralateral representation, right? So let's say the patient has brain tumor on the left side. Let's follow that, all right? Left side. So it will only take the lower part of the face, because the other one, the upper part of the face, will still has the ipsilateral representation. So it's about the representation in the brain rather than the decussation. So the forehead has bilateral representation in the brain. The temporal branch of the facial nerve has bilateral representation in the brain. All right, so let's do the neck triangles. All right, what are the boundaries of the posterior triangle of the neck?
So the boundaries of the posterior triangle would be sternocleidomastoid, trapezius, and the middle third of the clavicle.
And fine, what are the contents of the posterior triangle?
So the contents of the posterior triangle would be the carotid artery, the external carotid artery vein, the subclavian artery. I think part of the cervical sympathetic plexus. I think those.
So you can classify into nerves. Nerves will be phrenic, accessory, brachial plexus, cervical plexus. Vessels, external jugular vein, the subclavian artery. The external carotid is still in the anterior triangle. And muscles, will have lots of muscles. Omohyoid, scalene's muscle, scalenus anterior, scalenus medius, and scalenus posterior. You'll have supraclavian. So this is your posterior triangle. The tongue has some external muscles. Can you tell me the nerve supply of these muscles?
No, I don't know. I know they've got 3 different muscles and 3 different nerve supply.
They are mainly supplied by the hypoglossal nerve.
Yes.
Except palatoglossus, which is supplied by the glossopharyngeal nerve.
Yes.
Right. So they are all supplied by the hypoglossal nerve, except the palatoglossus, which is supplied by glossopharyngeal nerve. Hypoglossal, except palatoglossus muscle, which is supplied by the glossopharyngeal.
I haven't looked at the strap muscles apart.
That's fine. The strap muscles, we already talked about them. You shouldn't really worry about studying them, right? Because we already talked about them.
I know they're just supplied by ansa cervicalis, which is.
But the strap muscles are easy to remember because we already talked about them. If you remember that neck dissection diagram, all right? So you don't need to worry about that. Anterior triangle.
Yes.
Boundaries.
So you've got the midline. Anterior midline of the neck, you have the anterior portion of sternocleidomastoid, and then you have the angle of the mandible, the lower border of the mandible. And then you've got, I think, 3 triangles within that anterior triangle.
So you have the submental, submandibular, carotid, and muscular. So 4 subdivisions.
And they're all
submental, submandibular, carotid, and muscular triangle. What divides them? 2 muscles that divide them. What are these 2 muscles?
The anterior and posterior belly of the digastric muscle and the superior border of the omohyoid.
The superior belly of the omohyoid muscle. All right. Can you tell me the contents of the carotid triangle?
So you have the external carotid artery, you have the internal jugular vein, and then you've got the nerve, I think, that runs in between them. And then you have the cervical lymph nodes, and then the cervical ansa cervicalis.
Contents could be arteries, that's the superior throat artery, lingual artery, facial artery, occipital artery, ascendopharyngeal artery. And also you can mention the carotid, internal carotid and external carotid artery as well in the carotid triangle. The carotid sheath and its content, that's external carotid, common carotid, internal carotid, and internal jugular vein and the vagus nerve in between. And the structure crossing the carotid, that's the hypoglossal nerve, accessory nerve, and the ansa cervicalis, or crossing the sheath. All right. And the veins, they are similar to the arteries. This is very detailed contents. But if you want to be quick, you want to say the carotid sheath and its contents. And you also want to say the structures crossing the carotid sheath, ansa cervicalis, and hypoglossal nerve, and the accessory meningeal. Fine. So that's enough on the triangles. They can ask you questions in the triangles. Right. In terms of glands, why does the thyroid gland move with deglutition?
Why does the thyroid gland move with Is it to do with its embryological origin? No. So
the answer, the thyroid gland is part of the pretracheal fascia, right? So it's contained in the pretracheal fascia. And this pretracheal fascia is attached to the thyroid cartilage and the hyoid bone. So with deglutition, the hyoid bone will move, obviously, by the strap muscles and the muscles above. And that will lead to pulling the pretracheal fascia, and that will pull the thyroid gland. In thyroidectomy, what are the related or the potential nerve injuries that can happen?
So with a thyroidectomy, you could have risk to the external laryngeal nerve or the recurrent laryngeal nerve, and also the cervical sympathetic plexus.
Correct. What's the cell of origin of a medullary carcinoma?
So that would be your parafollicular C cells, which secrete calcitonin.
What are the late complications of thyroidectomy?
The late complications of thyroidectomy would be hypocalcemia and hypothyroidism.
How many parathyroid glands do we have?
2 superior and 2 inferior, so 4 in total.
What's the blood supply of the parathyroid glands?
So the blood supply of the parathyroid gland is predominantly from the inferior thyroid artery, which is from the thyrocervical trunk.
Correct. In terms of parotid, blood supply of the parotid gland.
The blood supply of the parotid gland would be facial artery? I'm not too sure.
That's fine. So the blood supply of the parotid gland, facially, it would be one of them, but you basically have the terminal branches of the external parotid artery. That's superficial temporal and maxillary, and also the posterior auricular artery. And the venous drainage will be the retromandibular vein, which drains into the external jugular vein. What are the structures that pass through the gland?
Structures that pass through the gland are the facial nerve, the external carotid artery, retromandibular vein, and a greater auricular nerve.
So you feel the lymph nodes, right? So the mnemonic feel the lymph nodes, right? Yeah. The facial, external carotid, auriculotempora, and retromandibular and the deep parotid lymph nodes. What's the parasympathetic supply for the parotid gland?
Not too sure.
So the parasympathetic is actually an important one to know because they usually ask this question on parasympathetic of all the salivary glands in general. So here you have the inferior salivatory nucleus will go through the glossopharyngeal nerve. So this is the inferior salivatory nucleus will go through the glossopharyngeal nerve, then the tympanic nerve and tympanic plexus, as you can see here, the lesser petrosal nerve, then go to otic ganglion, and finally the auriculotemporal nerve. So bottom line is your parasympathetic nerve supply the auriculotemporal nerve, but you have to know the pathway.
The nerve supply of the parotid gland would be the cervical plexus, no?
It's multiple things. So you need to mention, when you ask the nerve supply, you need to mention sympathetic and sensory. The sensory is your great auricular nerve because it's just above it. The sympathetic is your superior cervical ganglion, and the parasympathetic is your auriculotemporal nerve. What is Frey syndrome?
So Frey syndrome is where you have a injury to the nerve which regenerates. So you have more sympathetic nerve, so you have an increase in the number of secretions from the gland in response to a change in smell in the external environment, for example. So you have increased salivation.
No. So first of all, the question is asking about the syndrome, right? It's not asking about the pathogenesis. Still do the pathogenesis as long as you explain the syndrome, right? So what's the syndrome? So basically, every time the patient smells nice food or gets some stimulus that will increase the salivation, they will have sweating over the gland as well. So this is the syndrome. It's when you get sweating over the gland, when you're stimulated during the stimulation of the auriculotemporal nerve. So what actually happened? Actually, the auriculotemporal nerve that supplies the parasympathetic fibers to the parotid gland and also sympathetic fibers to the sweat glands just above the parotid. Damage of this nerve can cause irregular regeneration. And every time you're trying to stimulate your parasympathetic, you will stimulate your sweat glands as well. Then you would get the sweating every time you try to smell something nice or think about food. Cool.
So it's irregular regeneration of the following damage to the auriculotemporal.
So damage your auriculotemporal nerve, and then you'll have some irregular regeneration. And the parasympathetic fibers will also do a sympathetic response. So you will get sweating every time you try to eat or smell something nice, because that will be your sympathetic and parasympathetic activated at the same time. Right. So we haven't done vessels for sure, right?
I'm aware of, no.
What are the contents of the cavernous sinus?
So the contents of the cavernous sinus would be the trochlear nerve, oculomotor. I think it's TOMCAT, the acronym. So maxillary nerve. Not too sure of the others. You
can classify the contents into contents in the wall of the cavernous sinus and in the substance of the cavernous sinus. In the substance, you have, as you can see here, you have the abducen nerve and also the internal carotid artery. And in the wall, you have the fourth, and you also have V1 and V2. So thalamic and maxillary branch of number 5. So bottom line is you have the internal carotid and 3, 4, 5, and 6.
Is the syndrome where you get compression?
So the cavernous sinus syndrome is basically when you get some sort of, it's congestion of the cavernous sinus. It will be full of venous blood, basically. And this will cause pressure on all the nerves, right? So that will cause pressure on the abducent, pressure on the oculomotor, on the trochlear nerve. Patient can come with ophthalmoplegia and fixed dilated pupil, and also loss of, maxillary nerve, loss of ophthalmic nerve, etc., etc. All right.
And the infection spreads because
it could happen from the infection spread. That will be cavernous sinus thrombosis. Or, all right, can you identify here what is number 7, or this one that I'm pointing to?
The 7.
Can you see where I'm pointing to?
Is that, it's not a straight sinus, is it?
I'm curious to know, how did you work out that would be straight sinus?
It's draining from the...
So you need to divide the sinuses logically. If you know the bony anatomy, you'll be able to divide them. All right, that's your sella is here. So on both sides of your sella, you have the cavernous sinus. 7 is cavernous sinus. Cavernous sinus have some tributaries and some drainage sites. The tributaries, as you can see here, this is ophthalmic, this is a sphenopalatine, and this is the intercavernous sinus connections. And then you have here superior petrosal and inferior petrosal. It makes sense because this is the petrous bone. So you have superior petrosal and inferior petrosal as well. And this will go into the sigmoid sinus because it's a lazy S, as you can see here. On the back, you have transverse sinus,
which is number 2.
And you have a straight sinus.
1.
That is straight sinus. It's much more clear here. This is superior sagittal sinus, inferior sagittal sinus, straight sinus, occipital sinus, and this is the confluence of sinuses. They're meeting together in a single one. Right. So I want you to take a minute, look at this. I know it's a bit confusing. We can break it down into simple things, all right? This is the blood supply of the brain. It's divided into anterior circulation and posterior circulation. The anterior circulation is your ICA, the internal carotid artery, which divides into anterior cerebral artery and posterior cerebral artery, and middle cerebral artery. So anterior cerebral artery and middle cerebral artery. And this is your vertebral coming together as basilar, and then it gives off posterior cerebral arteries. So now you have anterior circulation and posterior circulation. We would like to connect this together. The way we can connect them or communicate them, you do communicating arteries. You have posterior communicating artery between the posterior cerebral and the ICA, or the other way around, between the ICA and the posterior cerebral. And you have the anterior communicating between the two ACAs. So this is now your circular phyllis. The other thing to remember is what are the branches of the ICA before the bifurcation or before giving MCA. The way I like to remember this is outpatient appointment, so OPA. Ophthalmic, posterior communicating, maxillary. Ophthalmic, posterior communicating, ophthalmic, posterior communicating, and anterior choroidal. That's OPA. Ophthalmic, posterior communicating, and anterior choroidal. You can see them very nicely here. This is ophthalmic, this is posterior communicating, and this is anterior choroidal artery.
That's from the branches of the ICA.
Before the bifurcation. Very important to know this. Before the bifurcation. Right. This is another angiogram that is very clear showing circular phyllis. You're looking from the top. This is your basilar artery. You have 2 posterior cerebral coming out from it. And in the front, this is the ICA. That's middle cerebral there. That's anterior cerebral. And that nice small branch communicating between anterior circulation and posterior circulation is called the posterior communicating artery, right? So we'll do a bit of identification here. Try to identify, we'll mention the important stuff, all right? What is it?
So the posterior communicating?
No, really. So I want you to follow this. What is A and B?
Posterior, inferior?
No, just try to go to the obvious stuff, right? So A and B is your vertebral artery coming together as basilar artery, and the basilar will end up dividing into
P1 and P2.
Posterior cerebral arteries. It doesn't divide into P1 and P2. So posterior cerebral arteries. So F is your posterior cerebral artery.
And E is the posterior inferior?
Oh, really? I'll take you back to
this.
We're literally looking at this. 2 vertebral artery going up, basilar artery, posterior cerebral arteries, and then the one below is the superior cerebellar arteries.
Yeah. And then basilar comes, so those come off the basilar.
Yeah. What about this big branch, H, on both sides?
I'm not too sure. That's not internal carotid. That'd be wrong.
Why not?
So I thought that would be G.
Well, H is actually your internal carotid and G is still your internal carotid as well, both sides. So H is still the internal carotid artery and G is internal carotid artery. So the reason why I'm coming to them is to actually go to K and J. What is K and what is J?
So K would be your middle cerebral, and then J would be your anterior cerebral.
Correct. Fine. There are multiple other things to identify. What's the abnormality in this scan?
I'm not too sure. Oh,
So looking at this one, it's this big balloon, right? So this is an aneurysm on the right MCA. Aneurysm on the right MCA. You have also multiple blips on the other side, on the other MCA, but this is the main one. That's a giant aneurysm on the right MCA. What's the abnormality on this scan?
So you have, is it either a thrombus or an embolus in the internal carotid?
There is something in the internal carotid, but it's still filling there, right?
Is it just stenosis of the internal carotid?
Yeah, it's stenosis, but it's still filling. But this one is not filling. Can you see this one? This filling nicely here, but this is not filling, right?
So is it anterior? No, it's not an anterior cerebral. Is it an M? It's not. It's a branch off an MCA.
It's the MCA. The whole MCA is gone. You only have the M1 there. This is the M1. Then the rest of the MCA is gone. Right? So the patient has a big thrombus at the side of the bifurcation of the MCA. Can you see the bifurcation here? And you cannot see any bifurcation on the other side. Do I need to answer this question again? What are the branches of the RCA before giving MCA?
So it's outpatient appointment. So it's the ophthalmic artery, the posterior communicating, and A is the anterior choroidal.
Yeah, fine. What can you see in this scan?
So this looks like a T2 MRI on the, it's not axial view, it'd be coronal view, I think. And it shows a hyperdense lesion in the, I'm not too sure, is it in the,
right.
it's not in
there are many things to correct here first before going forward, right?
It's compression of the
let's start from the beginning. So is this an MRI or a CT scan?
Oh, it's an MRI. I think it's an MRI.
It is an MRI, that's right. This, we have multiple sequence in MRI. This T1 or T2?
I think it's T2.
Why did you say T2?
Because the lesion is hyperdense, which means
it's not about the lesion. So the differentiation between T1 and T2, T1 is anatomical. So white matter is white, gray matter is gray. Can you see this is the white matter, which is less gray than this one? That's one thing. The other thing that you can do is the CSF. The CSF is black in T1. This is the CSF, which is black in T1. This is T1 scan. All right, that's first of all. So this is a T1 weighted MRI scan. What are the views? This is a coronal view and this is a sagittal view. All right, fine. What is the lesion here? So you have a left-sided, you said hyperdense. We never say density in the MRI, we say intensity. So hyper-intense. Left-sided parasagittal, because it's close to the sagittal sinus basically. Parasagittal, hyper-intense lesion, homogeneously enhancing. The dural base, because its base is the dura, and the dural tail as well. You can see the tail of that. Dural base and the dural tail. And it's causing mass effect. We agreed before the mass effect is three things. Those three things are placement of the sulci, compression on the ventricles, and midline shift. What's the diagnosis? We haven't said the diagnosis up till now. We just described the lesion.
So the diagnosis here would be either a primary brain tumor or a...
There is a single diagnosis here. It's very characteristic. This is the meningioma, right? Because the dural base, it's basically the dura and it has dural tail. It's only one diagnosis. You can always do differentials, but this one is meningioma. It's very classic. You can't really confuse it, right? What's the finding on this MRI scan? Describe the lesion again and then say the finding.
So this is a T1 MRI, which shows a lesion on the, I'm not too sure if it's right or left.
Like the CT scan, so that would be right side.
On the right-hand side in the temporal region of the skull, showing effacement of the sulci, midline shift, and compression of the, is it fourth ventricle?
That's not the fourth, that's the lateral ventricle. But you don't have to specify really, just it's compression of the lateral.
It looks like a mixed, it's not a homogeneous, it looks mixed because it's areas of white.
So, correct, so you want to say heterogeneous enhancing,
heterogeneous,
right?
That's, yeah.
With a ring enhancing area as well.
So this would be more infection.
Well, could be. So the differentials, what are the differentials for ring enhancing?
Glioblastoma multiforme, is that one? No.
That's one.
Cytomegalovirus, CMV?
Well, so the way I like to remember it is something called Dr. Magic, right?
Magic.
Demyelinating lesion, resolving hematoma, metastasis, abscess, GBM, infarction, contusion. The most two common are abscess and the GBM. GBM is a very old term that we don't like to use it. It's called glioma rather than glioblastoma multiforme. All right. It's a very old term that hasn't been used since the 90s, basically. Okay. GBM is a very old term. Fine. What are the attachments of the Tentorium cerebral?
I'm not too sure.
The attachment of the Tentorium, I'm not sure if I have an image here. So basically, you would go back to this one. This is your Tentorium cerebelli. The attachments, you will have the occipital bone,
the temporal bone,
and the petrous bone,
which is part
and
of the temple.
even the dorsum sella as well. As you can see, the attached part, and the anterior clinoid, right?
So it's basically just what forms the boundaries of the cranial fossa.
And just try to know that there is an attached part and there is a free part as well. And we know that the attached part compressed, the oculomotor nerve is compressed against, right? Fine. I think that's pretty much it for...
And the neck. And just to go over, so the sternocleidomastoid, you have the greater auricular running anteriorly, and then posteriorly you have the... No, not ansa cervicalis.
So you're talking about this. This is the sternocleidomastoid. Above is greater auricular nerve. Below is...
accessory. And then number 2 would be or 17 would be the ansa cervicalis.
No, 17 is your jugular, right? Because 17 is here as well. And 2 is your ansa cervicalis, yeah.
2 is the answer.